Today, I'm going to talk about a very dangerous development that's happening to our Medicare. This is called the privatization of Medicare. The reason that it's so important to me is when I turned 65, I felt a lot of relief knowing that I could sign up for Medicare, that I would be covered for my health care, and I could have a choice of wherever I wanted to go. But today, Medicare is going to the dark side. For a few years now, private Medicare Advantage programs have been enrolling seniors in their insurance plans. And now there are 48% of seniors nationwide that have signed up for Medicare Advantage plans. But now there's a little-known program called Direct Contracting Entities, which will soon have a name change called ACO REACH. And this will be taking over the seniors that have signed up for traditional Medicare and are not in Medicare Advantage programs. These DCE programs pose a major threat to seniors and their health care and to the future of Medicare. So today in my presentation, I'm going to explain why these entities, which we call direct contracting entities or ACO REACH, are so dangerous, why they must be stopped, and what we can do to stop them. My next slide is of a roller coaster. Why am I doing that? Because this is a very complicated subject. So I want you to hold on to your seats, and hopefully by the end of this presentation you'll understand even a little bit, because even with that amount of knowledge you will know more than 99% of the rest of the country, including politicians, including physicians. I hope you can then use this knowledge to share with other colleagues and friends and get them to understand what's going on with the privatization of Medicare. Let's start at the beginning. I signed up for traditional Medicare. Some of you may have signed up for traditional Medicare. Some of you may have signed up for Medicare Advantage. What traditional Medicare means is that there is a Medicare trust fund run by the government, and the payments are made directly to providers and hospitals. Traditional Medicare has many parts. There's Part A, which covers hospital insurance, Part B, which covers outpatient care, there's Part D, which covers drugs, and many seniors decide to buy some extra private insurance called Medigap to cover additional expenses. Unfortunately, with Medicare, vision, dental, and hearing are not covered. Then what happened in the late 1990s and early 2000s, a new program was developed under the Bush administration. And this program is called Medicare Advantage. So what is a Medicare Advantage program? As I mentioned before, these started in the 1990s, have gone through many permutations, and they're very popular now. What Medicare Advantage did was change the way Medicare pays for seniors' care. It provides Medicare benefits through the private sector, through a private, for-profit, usually, insurance company. Medicare makes monthly payments to these insurance companies, who then distribute the monies to providers and hospitals, and those who are disabled, because many people who have chronic disabilities are also eligible for Medicare. These companies are really middlemen, and they get in between the provider and Medicare, and they get in between you as the patient and your provider. They do contain parts A, B, and sometimes D, and sometimes they do provide vision, hearing, and dental, but usually to a limited extent. But their bottom line is to make money. So how do they do that? There's a number of ways they can do that. One of them is to minimize the expenditures on actual patient care. How do they do that? Well, they try to find seniors that are relatively healthy. So they may go to a gym and find seniors that are exercising, assume that they're usually a healthier bunch of people, and try to convince them to sign up for a Medicare Advantage program. That's called cherry picking. They also create networks where they contract with providers and hospitals, and then the senior who has signed up for Medicare Advantage is limited to the people who are in this network. So what happens if a senior gets really sick or develops some kind of very rare disease and they want to see a specialist that has expertise in that particular condition, or they want to go to a special cancer center, of which there are a few around the country, none of which, by the way, are in a network with a Medicare Advantage program. So the senior requests the provider to get authorization to get treatment from either a specialist or a special center. And often that is not authorized by the Medicare Advantage program because it would cost them a lot of money. So what choices does the senior have? Well, the senior can either stay in the Medicare Advantage plan and choose to see providers that are limited within the network, and it may not be the best care they could get, or they could leave. So what happens if they decide to leave? They have to wait for the enrollment period when traditional Medicare opens up, which is a few months a year. And then if they're interested in getting the supplemental insurance, the Medigap that I mentioned before, that is provided by private insurance companies to cover extra expenses, what happens is this is the one time that the private insurance companies do not have to provide insurance to a senior who has left traditional Medicare because they're considered to have a pre-existing condition. Now remember, when ACA was passed, they eliminated the idea of pre-existing conditions, so everyone was able to get insurance. However, this is the one exception where seniors may try to get Medigap or extra insurance and they won't be able to. However, the way that the Medicare Advantage plans make the most money is with something called upcoding. Well, here's an example of upcoding in action. Here's a chart that you can look at. Don't be alarmed. I will explain it to you. On the left is a chart of a 76-year-old female patient with some common diagnoses. Each of her conditions gets a score, and then the total score determines how much money Medicare will pay the middleman or the Medicare Advantage program. Remember, this has nothing to do with the actual care that's provided. It's just a description of the conditions. Now, let's look on the right-hand side, and you see the same patient when the middleman has engaged in the process of called upcoding. So how do they do this? Well, they do it in a number of ways. They send staff to circulate in hospitals and make sure when doctors discharge a patient, they try to get the most complicated diagnosis that the patient may have, regardless of whether they were treated for that or not. And then they can get more points for those conditions. Another thing that they do is they send out nurses and physician assistants and nurse practitioners and other staff to homes. It sounds great. You get a home visit. And they then go through the conditions, the initial conditions, and they ask questions to make them sound more complicated. So for example, our female here has depression, but you see that there is 0 points for that condition. So they then ask question to this woman and they say, well, have you been feeling a little blue lately? And the woman may say, yeah, I have. How long has it been? You know, it's been COVID. You've been home alone for over 2 years. And she said, yeah, I've been feeling pretty blue for that time. Well, up goes the code because that makes the depression more complicated from a 0 to a 0.3 plus. They do the same thing with the other conditions. For instance, asthma has 0 points on the left, but they can turn that into a more complicated respiratory condition called chronic obstructive pulmonary disease, and boom, you got a higher score. So when you add all the scores on the right, you get a much higher score, and look what happens. Medicare, instead of paying $9,000 for the initial codes that this generic female has, now gets $32,000 for this one patient. This is why Medicare has overpaid Medicare Advantage programs by $106 billion between 2010 and 2019. This is what is bankrupting our trust fund, our public Medicare. Let's look at how our healthcare system in this country is organized. President Biden appointed Xavier Becerra as Secretary of Health and Human Services. That is the department that oversees all the health care in this country. Under this department, under the Health and Human Services, there is a department called Centers for Medicare and Medicaid Services, whose acronym is CMS, and they manage Medicare. Now, the slide looks really blurry, and that's on purpose, because I don't want you to memorize all these different boxes. I just want you to focus on one of the departments, which is CMS. Under CMS, there are multiple departments as well. And the one that's circled is called the Centers for Medicare and Medicaid Innovation. And their mandate is to fund demonstration projects that will improve care and decrease costs. One of those programs is the direct contracting entity or REACH program. This department works under the radar. It doesn't need congressional approval. It can approve different demonstration projects and send them on their way to do whatever they say they're going to do. The person who runs this department is a woman named Liz Fowler. She's the director. She is one of the multiple people in this country that go around the revolving door between private industry and public office. She actually helped design the ACA, which really did help a lot of people obtain insurance and health care. If you look at how the ACA is run, it is based on a for-profit private insurance system. And it is our taxes that pay the subsidies that have enabled millions more people to obtain premiums. Our subsidies that pay the premiums that go to insurance companies. They don't go to health care. So she helped design that, and that is her MO. Before Liz Fowler, however, there was a man named Adam Bowler. And Adam Bowler was a former roommate of Jared Kushner, who you may know was the son-in-law of the ex-president. Now, he ran the Centers for Medicare and Medicaid Innovation when it was first starting in 2019 under the Trump administration. But before CMMI, Bowler ran a startup called Landmark Health, which then became one of the very first direct contracting entities to contract with Medicare. Well, let's go into what is this Medicare direct contracting entity? What is the ACO REACH? Well, Medicare makes a monthly payment to these programs, DCE or REACH, to manage seniors' care, and then is able to keep a certain percentage for overhead and profit. How the DCEs or the REACH programs get seniors to enroll is they approach physician organizations, and they lure these physician organizations to either sign up with their company or they actually buy the physician organizations outright. Once they have this contract with the physician organization, they then have access to all the claims data of the seniors that are seen by the physicians in that organization. And then they automatically, quote, align the seniors into their program. We like to say assign, but they like to use the word align. And let me be clear, these seniors are aligned into their entities without their consent or knowledge. They are enrolled automatically. Now, there are 99 of these contracting entities as of December 31st, 2022. In January of 2023, there will be an additional 123 of these companies. Virtually any company can apply to be a DCE or REACH middleman. They don't have to have anything to do with healthcare, no involvement at all. It can be Disneyland that decides to buy or form a DCE. And most of these DCEs are run by commercial insurance companies or by private equity investors. And at least a quarter of these DCEs are traded on Wall Street. Now, when a group of investors with multi-millions or billions of dollars want to invest in one of these programs, they form an organization that is the middleman, and they do not have to be approved by Congress. There's no oversight. They're all approved by the department I was telling you, the CMMI. So how does this all look? Well, remember, when we had traditional Medicare, we had a simple graph with a Medicare trust fund, a direct arrow to the provider. Then you come with Medicare insurance. You have a middleman that gets the money from the trust fund and then distributes it to the provider. Well, now we have a whole new set of investors that are flooding these newly created middlemen that are supposed to provide money to seniors. And these investors expect a very big return on their money. So the question is, how do companies who claim that they will improve care and save Medicare money make enough profit to keep their investors happy? Well, they maximize revenue from Medicare, they minimize revenue spent on patient care, and they enroll as many beneficiaries as they possibly can. They are allowed to keep as much profit and overhead as they can that they don't spend on medical services, which of course is a very dangerous incentive to ration and restrict seniors' care. Remember, these financial incentives do not exist in traditional Medicare. Now, what happens when a DCE approaches the physician organization signs up with the ACO REACH program, and then they're automatically aligned with the company? Well, they're not told ahead of time at all, but they do sometimes get a letter, and the letter looks like this. Now, if I got a letter like this, it says no action needed. And it has a lot of paragraphs that don't make a lot of sense except to say, gee, you're in a wonderful program right now and we're going to do all this for you. But it doesn't say I won the lottery. It doesn't say I have to pay a bill. What do? I throw it in the circular file. But there are, of course, many people who are more careful and diligent than I am. And they will read the whole letter. And they will say, I don't want to be in your company. I don't want to be in your entity. I'm going to call this company up and try to get out. So they call, and they get a pleasant voice on the other end, and the person will say, the senior will say, I want to get out, and the person will say, well, you can leave, but what does that mean? That means that the senior has to leave their primary care physician. And this can be especially difficult for seniors in rural or underserved areas. Asking seniors to change primary care physicians undermines traditional Medicare's promise of free choice. We lose that choice. But the senior can leave, so that's what they call choice. They can leave by leaving their primary care doctor. In December 2021, a group of 30 doctors from Physicians for a National Health Program, which is the organization that I belong to, went to Washington with a petition of about 10,000 signatures. Some of you may have actually signed it. And they wanted to present it to Secretary Becerra, who, with a stroke of a pen, could terminate these programs. Well, they weren't allowed to in the building. It was in the middle of winter. But Liz Fowler came out, the woman who runs Centers for Medicare and Medicaid Innovation. And she was apparently very charming and explained that she really believes that these entities will save money and improve care. With these physicians starting the publicity of what's going on with these private entities, more and more people became outraged. And with that publicity and education, there was a big outcry. So what did the Center for Medicare and Medicaid Innovation do? We wanted them to stop the program, but that didn't happen. What happened was they changed their name. They changed their name from direct contracting entities, and they will now, as of January 1st, be called ACO REACH, which stands for Accountable Care Organization Realizing Equity and Community Health. So what does that mean? Well, what it means is that they promise to improve equity, access to health care, and they promise to do this for underserved communities. So Medicare will now pay an extra $360 for every senior that comes from a poorer neighborhood. And then what they can also do, these programs can then add, quote, social determinants of health, such as race or poverty, in the scorecard that we initially looked at that only covered medical conditions. Now it can cover race, it can cover income, it can cover lack of transportation. And with all those extra points, Medicare will then pay an extra amount to these entities, and that will drive up costs a lot. The other thing that they do is that once they are approved by CMMI, once they are approved, that's what I just said, they then have to fill out a template that says what they're going to do to improve equity. Now, this template, which I have seen, looks like a homework page from elementary school. And they're supposed to fill it out, explaining how they're going to improve access for everyone, but then there is no accountability, none at all. They don't have to come up with any plans that they have to actually show work. I think, personally, this is very shocking. And it is taking advantage of underserved communities by extracting money from Medicare to supposedly cover health care for them, but actually not providing extra care at all. Let's take a look at the difference between direct contracting entities, soon to be called ACO REACH, and how it differs from Medicare Advantage. Medicare beneficiaries in Medicare Advantage programs actually choose their plan, and they're able to weigh the savings versus the risk. Now, there's a lot of slick advertising on TV. I'm sure many of you have seen it, and they don't always tell the whole truth. They gloss over a number of the issues that I mentioned earlier in this talk. However, they do have a choice, whereas those seniors that are put in the REACH programs did not choose them. Medicare Advantage plans can keep up to 15% of the money that they get from Medicare for overhead and profit, whereas the REACH programs can keep up to 40%. A very good investment if that's the kind of mindset that you have. Medicare Advantage programs were approved by Congress. The REACH plans have not been. Why should we stop these? Well, as I mentioned before, when programs like Medicare Advantage and now on steroids, the DCE REACH programs extract so much money from Medicare, then it is threatening Medicare solvency. And in a number of years, we may not have a public trust that ensures health care for our seniors. And in that way, it threatens seniors' health, and it definitely takes away the choices that traditional Medicare promised. Let's look at these pies. There are three pies here. On the left, we have traditional Medicare. And if you look, there's a small sliver, a yellow sliver, that is the amount that traditional Medicare actually pays for administration. It's not a for-profit entity, so it only pays for administration, and it's 2%, which means 98% goes to patient care. With Medicare Advantage, they're allowed to keep 15% for overhead and profit, and patient care gets 85%. Once again, with the ACO REACH entities, they're able to keep 40%, and only 60% goes to patient care. But to get that 40%, medical care is very expensive, so they may not be able to please their investors by just rationing care for seniors, because they still have to pay something. So they will find other ways to game the system. And there's pages and pages of details that I don't understand, but I did glean some of the ways that they may game the system. One of these is that the Medicare Advantage programs have what's called a quality withhold for failing to meet certain criteria of care of 5%. In other words, if they don't meet a certain amount of quality metrics for their patient population, then they have to actually return a chunk of money to Medicare. Now that 5% drops to 2% for the REACH programs. So the REACH programs have less incentive to provide good care for their patients. Another way that they do this is that when the ACO REACH gets the money from Medicare, they are able to keep 100% of the first 25% drop in spending. What does that mean? It means that if they reduce the care for a senior from $10,000 to $7,500, they get to keep the entire $2,500 initially. So this is some of the ways that they're trying to ensure they can get that 40% to please their investors and then have stocks rise on Wall Street. Why should we stop these ACO REACH programs? Well, it's a radical transformation of Medicare. The Center for Medicare and Medicaid Innovation plans to expand ACO REACH to all of traditional Medicare by 2030. That means we have about a little over 7 years left to stop this development. They write it in a very nice way. They say the aim is to increase the number of beneficiaries in a care relationship with accountability for quality and total cost of care. Translated means we're going to privatize all of Medicare, and we're going to do it by 2030. And here's an example of what's happening right now. We have Amazon just buying a physician organization south of San Francisco called One Medical, which is already partly a DCE, and you know that Amazon's bottom line is profit. Bezos' bottom line is profit. So they will apply all the techniques they know to extract as much money out of the healthcare system as possible. And what's very interesting, what I just learned recently, was that Medicare is so much more profitable to extract money out of than even our whole entire private for-profit insurance system. So a private for-profit insurance company that provides health care to everybody makes less money than an ACO REACH entity can make out of extracting money from Medicare. Now, I've told you a lot of doom and gloom stuff, but I'm going to change my tack right now. There are some good things happening. Some unions, once they understand what is happening to their retirees, are passing resolutions and sending their own congressional delegates to Biden and Health and Human Services. The Seattle City Council has passed a resolution to stop these DCEs. The Arizona Democratic Party and the Arizona Medical Association have actually endorsed resolutions to end and terminate DCEs. And even the American Medical Association has written, it is a tepid letter, but it is a letter to the physicians warning them to be very careful about signing up with DCEs. And there are organizations like Healthcare for All, like Physicians for a National Health Program, like Healthy California Now, like Healthcare Now. They're all over the country, and every one of them is becoming more involved in educating the public about this terrible development of privatizing Medicare. We have a great spokesperson in the House of Representatives named Pramila Jayapal. She represents Seattle. She is one who, a number of months ago, informed her colleagues about this development and then sent a letter with 54 signatures from her representatives to Biden and Becerra to terminate the program. We can call Biden, we can write Biden, and we can say, terminate these ACO REACH programs, because he can do that, because it takes away our choice, it takes away our insurance and relief to know that we're covered right now, because it'll all be gone if this continues. Our own representative in this area, Northern California, Jared Huffman, also signed on to this letter. Elizabeth Warren actually held a hearing about DCEs to try to educate the public and educate her fellow senators about what's going on. Because remember, there is no congressional oversight of these programs. One of the ways you can get more information and what you can do is, if you're a member of a union, if you're a member of a political caucus, you have friends, you have colleagues, let them know what's going on. Even if you only gleaned a little bit from this presentation, this is a bad thing. Start looking into it. And one of the ways you can get more information is to go to a website called protectmedicare.net. This is a great website that will give you lots of information, and it also has some petitions you can sign either as an individual, or if you're a member of an organization, you can have the organization sign on to this petition, which will be sent to Biden and Becerra to try to terminate these programs. Let me recap basically what I just reviewed. These direct contracting entities and the REACH program are handing over traditional Medicare to Wall Street by inserting profit-seeking middlemen in traditional Medicare and assigning seniors without their knowledge or consent. They're putting profits ahead of the patient care, and their plan is to expand profiteering to all of Medicare. We need to tell President Biden and Congress to stop Medicare DCEs and ACO REACH. And remember, to learn more and take action, please go to protectmedicare.net, because we need to expand Medicare so everyone is in Medicare. We don't want to privatize it. We need to supersize it.